Hello friends, I am Dr. Deepak Garg. I am consultant orthopedic surgeon and today we will discuss about principles of revision total knee arthroplasty and how to balance gap during the surgery. So we will discuss step by step. So when we talk about step by step, so we will take a 3-step approach that is called a Vince technique. So first we will prepare the tibia. We will take the proximal tibial cut perpendicular to the mechanical axis and we will cut the as minimum bone as possible. And once we prepare the tibia, we will apply the base plate and then we prepare the femur. So when we prepare the femur, we will first look at the flexion gap. We will first balance the gap, flexion gap. So tibia is prepared, knee is 90 degree at 90 degree range of motion, and then we prepare the posterior condyles of the femur and then we balance the flexion gap. So once we balance the flexion gap, then we go to the extension gap balancing. So we cannot do extension gap balancing before the flexion gap balancing. So we have to do the flexion gap balancing, then only we will go for the extension gap balancing. So let's look at these step by step in detail. So let's look at the skin incision. So skin incision we will take over the previous scar, usually the midline incision, and we will take a standard medial parapatellar approach. And if the range of motion is less than 70 degree under anesthesia, then we will have to do additional procedures like quadriceps snips, patellar turn down or tibial tubercle osteotomy. For the approach, we have a different video where we have discussed about which procedure is best in which situation. So once we have approached the knee, then we will go for the implant removal. So first we will do the polyethylene removal so that we will get the space for removal of other components. Then we will remove the femoral component. For that we can use a giggly saw, oscillating saw or osteotomes. And we will try to preserve as much bone as possible. Then we will remove the tibial component after the removal of the femoral component, because then only we will get the space to remove the tibial base plate. So for the removal of the tibia, we can use a saw at the bone prosthesis interface or the cement prosthesis interface, and we can use the various osteotomes from the medial and the lateral sides, and then we can push the tibial component outside. Then if there is a patellar component also, then we will have to remove the patellar component. Then for that we can use osteotomes, saws or high speed burr. So this is how we will remove the components. So once we remove the components, then we will wash the surgical field and then we prepare for the tibial reconstruction. So now what are the principles for the tibial reconstruction? For tibial reconstruction, so we have already seen that we will cut the proximal tibial cut perpendicular to the mechanical axis, and we will use an extramedullary guide for this, because the intramedullary guide is less reliable, because there may be some cement remaining, or because of some previous surgeries there may be a wide canal. So extramedullary guide is more reliable for taking proximal tibia cut. We take it perpendicular to mechanical axis. And for secure fixation of the tibial component, we may use a longer stem, and we may use it cemented or press fit or hybrid stem. Hybrid stem are also used nowadays. So hybrid stem is we use cement only in the base plate component, and stem we use as press fit uncemented. So that is hybrid. Then we will have to manage the proximal tibial defect. For example, if there is a defect in the one condyle or both the condyle, we may use blocks or wedges. If there is a metaphyseal defect, we may have to use cones or some other structural grafts. And sometimes if there is a large defect, we may have to use sleeves also. Then we will have to do a correct rotation. For the revision knees, the best way to maintain a proper tibial base plate rotation is using a static method, where we use a medial 1/3 and lateral 2/3 junction of the tibial tuberosity. So this is a principle of tibial reconstruction. So once we do the tibial preparation, then we will use the tibia as a base and then we prepare the femur. So then after the tibia we will establish the flexion gap. So we keep the knee at 90 degrees. We determine the femoral size considering posterior bone loss. So we imagine that we have a knee at 90 degree. Now we are looking at the flexion gap, and the tibia is already cut and fixed. Now only thing that can change is the posterior femoral condyles. And then how to balance the flexion gap when there is a loss of bone on the posterior condyle. So if there is a loss of the bone on the posterior condyle, then we will not use posterior condyles for rotation. Even if there is no loss, avoid choosing posterior condyles for rotation. Use epicondylar axis, right side line, or a tibial cut as a reference for maintaining a femoral rotation. If the flexion gap is loose, then don't downsize the femoral component. We will try to restore the posterior offset or the height of the posterior femoral condyle with using augments on the posterior condylar side. If the gap is asymmetric, then we will not accept the femoral malrotation. We will take the we will apply the femoral component. We will take it to the rotation, medial, internal and external, and we will see where we can balance or make the flexion gap rectangular. We will use that rotation. So we will change the femur rotation and try to have a rectangular gap. If still there is a difficulty in the balancing, then we will not touch the tibia, or we will not increase the tibial cut. Tibia cut, we keep it as fixed. We adjust only on the femoral posterior condyles. So these are how we will achieve the exact flexion gap. So let's look it again in another way, how to establish AP sizing. So for AP sizing, if the flexion gap is not rectangular, we must have to restore the posterior condyle offset. We will not downsize the femur. We may use augments or blocks on the posterior condyle. We will not downsize the femur. So only after the flexion gap is balanced, then only we will move to extension gap. So considering these things in mind, what are the principles of femoral reconstruction? So first, we will definitely balance the flexion gap. So to balance the flexion gap, we should have an exact anteroposterior sizing of the femur. For that, we will try to choose a larger component, not a smaller component. If needed, we will use the posterior augments. We will use posterior augments, and we will not downsize the femur. We will use a larger component. And for rotation, we will use a epicondylar axis or tibial plane at 90 degree. We will not use the posterior condyle as we usually do in a primary knee. We will not do it in revision knee. Then only we will move to the extension gap, that is the distal femur cut, and the distal augments we will use only if there is a if needed to balance the extension gap. So then to equalize the extension gap, so distal femur is usually deficit in most of the revision knees. When we take out the femoral component, usually there is a loss of some bone from the distal femur. So if the loss of the bone from the distal femur is more than 5 mm, then definitely we will have to use the distal femoral augments to restore the joint line. So restoring the joint line is necessary to achieve the good survival of the implant, stability, and good success of the surgery. So we will try to recreate a natural valgus angle of the distal femur, that is 4 to 7 degrees, and then how will we achieve the joint line properly? For that, the most reliable indicator is a medial epicondyle. So the medial epicondyle roughly lies 3 cm above the joint line. This is the most reliable method during the revision total knee arthroplasty. What we will do is we will expose the medial epicondyle. We will go medial. We will cut the tissues, and we will look at the insertion of the medial collateral ligament. The insertion of the medial collateral ligament is at the medial epicondyle. We find that insertion and we will go 3 centimeter below that line, and that is the joint line. So we will try to maintain our joint line. According to that, we may use distal femoral augments to maintain the joint line. Another indicator is a lateral condyle, that is of roughly 2.5 centimeter from the joint line. Then we have a meniscal scar. Meniscal scar, if visible, then it is also one of the very reliable indicator. It is lies directly on the joint line. Then we have fibular styloid. Fibular styloid usually lies approximately 1 centimeter below the joint line. So this is how we balance the joint line and make the distal femoral extension gap balancing. Now let's look at the decision making during the gap balancing. This is a table that will guide us. So this is a flexion gap and this is a extension gap. So if the flexion gap is tight and extension gap is tight, then definitely that means we will use a thinner insert. And if the flexion gap is okay, but the extension gap is tight, then if the flexion gap is okay, extension gap is tight, then that means flexion gap is okay. That means we have already balanced the flexion gap. Then only we have moved to the extension gap, and that is tight. In that scenario, we may have to remove any distal femoral augments if we have used any augment, or we may have to remove the distal femoral by 1 to 2 mm. We may have to do the distal femur resection. So we already know that we will first have to balance the flexion gap. So if the flexion gap is tight, then we cannot go for balancing the extension gap. So this is not a question that we will have to go for the extension gap. We will first have to balance the flexion gap. If the flexion gap is tight, then we will have to first balance the flexion gap only. Then we will have to do the femoral adjustment. We may have to use the undersizing of we may have to do the undersizing of the femur in those scenarios. And if the flexion gap is loose, then we may have to increase the femoral size and may have to use the posterior augments. So there is no question of balancing extension gap or thinking whether the extension gap is tight or loose. We will just think about the flexion gap and we balance the flexion gap. It is okay, it is okay. If it is tight, we will downsize the femur component. If it is loose, we will use the augments and we may have to increase the component sizing, femoral component sizing. Then if the flexion gap is okay and the extension gap is tight, here we have to remove the distal femoral augments or distal femur resection by 1 or 2 mm. If both are okay, then that is perfect. But if flexion gap is okay and extension gap is loose, then may have to use the distal femoral augments or upsize the component. So this is how we will do the gap balancing. Now once we apply the femoral components and the tibial components, then we will have to look at the constraints, and we may use a normal PS, posterior stabilized insert. So most of the cases, if the ligaments are normal in revision knee, we will use only PS. But if there is a unidirectional instability or a mild gap mismatch, then we may have to use a valgus varus constraint insert. Or if there is a global instability, both medial and lateral, or the ligament is completely torn, then we may have to use a rotating hinge platform. So this is how we choose about the constraint. Then about the polyethylene thickness, usually in revision knees 10 mm is very common. We may have to use 10 to 15 mm, and we just have to balance the joint line that we have already discussed. Then ligament balancing, sometimes we may have to release the ligaments which are very tight, or loosen the release some tight ligaments. Then intramedullary stem, we have already discussed 3 types: cemented, press fit and hybrid stem. These days we use a hybrid system where we apply cement only in the component, and stem that we use is a press fit uncemented stem. So this was about the principles of reconstruction in revision total knee replacement. Thank you for watching this video. For more such videos, please like, share and subscribe to our channel. Thank you guys.